It turns out that anxiety, often seen as purely pathological, is actually a spectrum, ranging from an essential survival mechanism to debilitating panic. And understanding this gradation is crucial for accurate diagnosis and treatment.
Really? I always thought anxiety was just anxiety. Like, you either have it or you don't. But a whole spectrum?
Yeah, exactly. And that matters a lot because misinterpreting normal or mild anxiety as pathological can lead to overtreatment, while missing severe anxiety or panic can result in poor outcomes and chronic disability.
That's huge. So by the end of this, we're really going to get a refined understanding of anxiety disorders, gradations, their clinical presentations, and how they intersect with other psychiatric diagnoses, right?
Absolutely. Plus, we'll touch on mood, psychotic, and personality disorders, and even critical medication side effects that often get overlooked.
Perfect. So let's start with anxiety itself. It's a fundamental human emotion linked to apprehension and uncertainty about potential threats, but it's distinct from fear, which is a response to an immediate, known danger.
Right. The document breaks anxiety down into 5 levels: normal, mild, moderate, severe, and panic, each with distinct cognitive and physiological profiles.
Okay, so normal anxiety is adaptive, necessary for survival. It motivates decision-making and helps us cope with change.
Exactly. Then mild anxiety actually enhances perception and problem-solving. People at this level have sharper focus and better cognitive processing. Physical symptoms are subtle, things like restlessness or nail biting.
That makes sense, like when you're a bit nervous before a presentation. But it actually helps you concentrate.
Yes. Now, moderate anxiety is where things start to narrow. The perceptual field shrinks, cognitive clarity diminishes, but learning and problem solving are still possible. Physical symptoms intensify: pounding heart, elevated pulse, gastric discomfort.
So this is a critical threshold clinically, right? Because anxiety begins to impair function but is still manageable.
Exactly. Then, severe anxiety is more disabling. The perceptual field is greatly reduced, often fixating on one detail or scattered details. Learning and problem solving become impossible. Behavior becomes automatic and confused. Physical symptoms include nausea, dizziness, trembling.
That sounds like a state where clinical intervention is really needed.
Definitely. And then panic is the most extreme level: loss of environmental awareness, possible hallucinations, or false sensory perceptions. Physical manifestations include pacing, shouting, screaming.
And panic attacks are hallmark features of panic disorder, which involves recurrent episodes and significant behavioral changes lasting weeks.
Right. This gradation model is clinically useful for assessing severity and tailoring interventions, avoiding the pitfall of treating all anxiety as pathological.
What about phobias? The document lists a bunch, including some I hadn't heard of, like triskaidekaphobia, fear of the number 13.
Yeah, phobias are persistent, irrational fears leading to avoidance behaviors. Recognizing specific phobias is important for targeted behavioral therapies.
And then there's generalized anxiety disorder, which is characterized by persistent, exaggerated worry linked to self-beliefs about the necessity or danger of worrying itself.
That metacognitive aspect complicates treatment because worry becomes part of the person's identity. They might believe that worrying prevents problems, or that not worrying is itself problematic.
That's a tricky loop to break clinically.
Exactly. Moving on, somatic symptom disorder involves a complex interplay of physical symptoms and abnormal thoughts, feelings, and behaviors. The distress or impairment is disproportionate to the medical seriousness of symptoms, often comorbid with depression or anxiety.
So it really highlights the importance of integrating physical and psychological assessments, avoiding reductionist approaches.
Yes. Then, obsessive-compulsive disorder is defined by persistent obsessions, intrusive thoughts, impulses, or images causing severe anxiety, and compulsions, which are ritualistic behaviors performed to reduce anxiety temporarily.
The relief is transient, so the behavior repeats. The distinction between obsessions and compulsions is critical for diagnosis and treatment planning, especially cognitive behavioral therapy.
Exactly. Now, depressive disorders. Major depressive disorder is defined by depressed mood lasting at least 2 weeks, with episodes potentially lasting months. About 1 in 5 cases become chronic.
And the subtypes are important clinically. Psychotic features include hallucinations or delusions. Atypical features involve vegetative symptoms like hypersomnia and overeating. Catatonic features show non-responsiveness and psychomotor retardation.
Postpartum depression onset is within 4 weeks after delivery, often with psychotic features, increasing risk to the infant. Seasonal affective disorder emerges in fall or winter, improving in spring, with symptoms like anergia, hypersomnia, and carb craving.
These subtypes definitely influence treatment choices and prognosis.
Absolutely. Then, bipolar disorders. Bipolar 1 involves severe mood shifts, including manic episodes with euphoria, decreased need for sleep, risk-taking behaviors, and impaired functioning.
Bipolar 2 has at least one hypomanic episode, which is less severe, and one major depressive episode.
Cyclothymic disorder is chronic, fluctuating mood with hypomanic and mild depressive symptoms not meeting full criteria for bipolar 2, lasting at least 2 years.
And rapid cycling is defined by 4 or more mood episodes per year, sometimes cycling within days or even hours, which complicates management.
Right. Understanding these distinctions is vital for accurate diagnosis and avoiding misclassification as unipolar depression.
Now, psychotic disorders. Psychosis is defined by altered cognition, perception, and impaired reality testing.
Schizophrenia is a heterogeneous group with overlapping etiologies, poor functioning, and brain structural abnormalities.
Schizophreniform disorder has similar symptoms, but lasts less than 6 months and may progress to schizophrenia.
Brief psychotic disorder is sudden onset psychosis, lasting less than 1 month, often stress-induced, with full recovery.
Schizoaffective disorder involves concurrent affective and schizophrenic symptoms, not due to substances or medical conditions.
Delusional disorder is characterized by non-bizarre, fixed delusions without marked functional impairment or odd behavior.
Differential diagnoses requires careful exclusion of substance-induced or medical causes.
Key symptoms include delusions, hallucinations, disorganized thinking, abnormal motor behavior, and negative symptoms, which are the absence of normal functions.
Moving on to eating disorders. Anorexia nervosa involves intense fear of weight gain, distorted body image, low BMI with restricting and binge/purge subtypes.
Bulimia nervosa includes recurrent binge eating with compensatory behaviors like vomiting or laxatives, with self-image heavily influenced by body image.
Binge eating disorder involves binge episodes without compensatory behaviors, often preceded by emotional distress.
Less common are pica, which is eating non-nutritive substances, and rumination disorder, characterized by regurgitation and re-chewing of food.
Personality disorders are grouped into clusters. Cluster A includes paranoid, schizoid, and schizotypal disorders. Odd or eccentric behaviors, social isolation, suspiciousness, magical thinking.
Cluster B involves dramatic, emotional, or erratic behavior, borderline, narcissistic, histrionic, and antisocial personality disorders.
Borderline is marked by emotional instability, impulsivity, splitting. Narcissistic by entitlement and low self-esteem. Histrionic by dramatic, flamboyant behavior. Antisocial by disregard for others' rights.
Cluster C includes avoidant, dependent, and obsessive-compulsive personality disorders, anxious and fearful behaviors, social inhibition, clinging, perfectionism.
Finally, medication side effects. Extrapyramidal symptoms include acute dystonia, akathisia, pseudoparkinsonism, and tardive dyskinesia.
Dangerous reactions include neuroleptic malignant syndrome, which is life-threatening with rigidity, hyperpyrexia, and autonomic instability.
Agranulocytosis, especially with clozapine, requires regular blood monitoring due to severe white blood cell drop.
An anticholinergic-induced delirium, mostly in older adults, can cause stupor and coma.
So understanding these nuanced gradations and overlapping features, along with vigilance for medication side effects, is essential for expert clinical practice and optimizing patient outcomes.
Exactly. It's about seeing the full picture, not just symptoms in isolation, but their severity, context, and treatment implications.
That's a wrap then. A complex landscape, but one that demands our full attention.
Absolutely. Thanks for unpacking this with me.
Anytime.